So first of all, congratulations to all of you for completing your master's degree. It's a great day. It's also a wonderful day outside, so the timing is perfect for that. Since you all have invested time and effort into developing expert knowledge in healthcare communication, I'd like to share with you a little bit about what I've learned from working in this field, in the hope that some of it may be helpful to you all as well. So my comments will be initially somewhat academic, and then maybe after that a little bit more personal. So as Bruce mentioned, my work has been in contextual error, which is a concept which you just got a brief taste of. If you think about it, when somebody goes to the doctor because they've lost control of their diabetes, or they're confused about a medication, and the physician is so intent on essentially just looking at the numbers, adding more medication rather than finding out what's going on, what you end up with is a care plan that looks great in the chart. If you were to audit that note, it would be, well, okay, this patient came in, their diabetes was out of control, the doctor increased the insulin, they referred them to a specialist, sounds good to me. But if you actually knew the backstory, you might discover that that person's vision was failing and they couldn't read their insulin syringe and they needed a pre-filled syringe. Or you might discover that they worked the night shift and they can't take their medication the way they used to. And if the physician knew these things, they would hopefully take a very different approach to care. And so when I started to see a lot of this, we needed a word for it, and we called it contextual error. So there was a case that had a huge effect on me. It was kind of the tipping point. It was around 2002, which gives you an idea of how long I've been working in this area, that I want to tell you about. And I'm going to call this woman Ms. Dawson. So Ms. Dawson had come to the preoperative testing clinic where I was working, supervising residents, and she had been referred for bariatric surgery. So this was a woman who was obese, and she had tried to lose weight in more conservative ways. She'd taken medication. She had been in a weight loss program, but she nevertheless developed diabetes and hypertension, and really, at this point, qualified, if you want to use that word, in a sort of guideline way for having bariatric surgery. And so that's how she ended up in this clinic, which is sort of the last stop before you go to the operating room. And when the resident saw Ms. Dawson and came back to tell me about her, the resident presented this as a very straightforward case and said, I don't think there's much we need to do here, maybe an EKG, but I think she's good to go. So we were walking down the hallway to Ms. Dawson's exam room, and the resident almost casually said, she even said that she's looking forward to having the surgery so she can take better care of her son. And I said, well, what's wrong with her son? And the resident said, I don't know, kind of shrugged. So when we got into the exam room, I said to Ms. Dawson, I understand there's something going on with your son. What's up? What's happening? And so a story came out, and it turned out that her son, who was in his early 20s, had Duchenne's muscular dystrophy, and was really at a kind of an end point in his life. He required total care. He couldn't feed himself. She would lift him. She would bathe him. She would toilet him. Her role was really to care for this young man. And in addition to that, she was also the sole caretaker for a 10-year-old daughter. She did actually have a husband, but he was an alcoholic. He brought in some disability money, but he didn't really help out in any way. And so it became clear that she was sort of at the center of holding this family together, and she'd been so focused on the positives of losing weight, being more active, that she really hadn't thought about the complications of just having surgery and not being able to lift anything for a while. And in fact, what made it even more complicated is she'd had prior surgery, so she had scar tissue in her abdomen, so they would have to do an open incision. They couldn't just do a little laparoscopic procedure. So she really wouldn't be able to lift anything for about 40 days that was, as heavy as lifting her son. And so when we started to talk about this, I suggested, well, could he go into a nursing home for a few weeks? Is there someone else who could help? And those were absolutely out of the question for her. She needed to be there for her son. And it became clear to her that once all this information was integrated, this was no longer the right decision for her at this time. And she canceled or basically indefinitely postponed the surgery. So when she left, it occurred to me that we had averted a kind of medical error. Ordinarily when you think about medical errors, you think about giving somebody the wrong drug or the wrong dose of the right drug or operating on the wrong limb, something like that. But in this case, the care would have looked right on paper. It would have looked like this woman had gotten the right care. but in fact, if you knew the context, the care didn't make sense anymore. And so that's why we decided to call this a contextual error. And at this point, I had started to notice that this was a common problem in healthcare, and one that was invisible when you just looked at the medical record, which is usually how healthcare is measured. It's usually evaluated by just looking at what's in the chart. To know what was going on here, you had to actually know what was being talked about. So I turned to a friend and colleague of mine named Alan Schwartz. Alan is a cognitive psychologist. He's not a physician, and actually he's given lectures in your program, although I don't think this year, and someone who Bruce knows very well. And Alan said, well, what about secret shoppers? So what if we train actors to portray the cases you see, to go into practices consistently and say things like, I'm looking forward to taking better care of my son. Let's have them carry an audio recorder, and we'll get permission from the doctors, but they won't know when they're seeing a fake patient, and let's see what happens. So we designed a bunch of cases. One case that I just want to mention because it kind of illustrated it was a 44-year-old guy I'd seen. We trained actors to do this, who had asthma that had gotten worse because he could no longer afford an expensive brand name inhaler that some doctor prescribed for him when he lost his health insurance. And so now, and he didn't realize that there was a much cheaper generic, that alternative. So when he came in, he casually said, boy, it's been tough since I lost my job. So we turned that into a case. We trained an actor to do that over and over again. And we sent that actor into initially 50 practices, and then we had another actor do another 50. And those doctors were everywhere. They were at Northwestern, actually quite a few here, at Loyola, at Rush, at UIC, in the VA, at John Stroger Hospital. But they were always doing the same thing, and they were always recording the visit. And so let's just take the asthma example. Essentially, we found three things when we listened to those audio recordings. You could kind of break down what the doctor did into three categories. One is they were so busy typing their note, they just didn't really even hear the comment. So the patient would say, boy, it's been tough since I've lost my job. And you'd hear click, 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 click. Okay, that was it. The other third, the doctor would say something that sort of was empathic sounding, but probably not that sincere. They would say something like, yeah, it's a tough economy. Do you have any allergies? And like, you just keep going. And again, you could sort of imagine that they were looking at a checklist of things that they were trying to get through. And so, not very helpful. And then maybe a third of them would say, how has it been tough since you've lost your job? And then they would hear that the patient couldn't afford to take their medication as directed. They were taking it every other day. They were stretching it out. And the doctor would usually say, well, actually, there's a much cheaper generic. And they would switch them to that cheaper generic. And the patient would walk out with a prescription and a plan that was going to work for them. The other two-thirds, they would get more medication they couldn't afford. They would get referred to subspecialists. They would have pulmonary function tests ordered, all sorts of stuff that, well, it's good for the pharmaceutical industry, but it certainly isn't good for the patient. And so these are contextual errors. So after we did that for a while, we decided, well, what happens with real patients? So we did another project where we invited real patients to carry concealed audio recorders into their visits. And again, we got permission from the doctors to not know when they were being audio recorded. Now with the fake patients, we told the doctor after they put their note in so we could cancel all the orders. With the real patients, they just agreed to record their visits, and the physicians agreed that as long as we didn't use their names and we de-identified the data, it didn't really bother them because, they were just going to provide usual care. So in our first study, we actually enlisted 600 real patients to audio record their visits using concealed audio recorders for us. It's quite a number. And then we started adding on their visits with nurses and with pharmacists and even with front desk clerks. And this whole approach has snowballed. Right now, my team is enlisting about 1,000 patients a year to audio record their visits in 6 cities. So we're doing this on quite a large scale. So we have a lot of opportunity to hear what happens during the doctor-patient encounter or the nurse-patient encounter or the pharmacist-patient encounter. The difference, of course, is we don't know what's going to happen. With a fake patient, it's fake. You decide what's going to happen. You know what the actor's going to say. With real patients, we don't know what's going to happen because it's real care. But we listen with the audio recorder, and we've discovered there are really 4 things we need to listen to. And this is very relevant to the field of communication from a process standpoint. So first, is there a clue that the patient is struggling with a life issue that might be complicating their care? It could be something they say, or it could be something in the chart, like they've been missing a lot of appointments, or they've lost control of their diabetes, or they're not refilling their meds. We call that a contextual red flag. Then the second thing we listen for is if there's a contextual red flag, Did the doctor notice it? Did the healthcare professional notice it? Did they ask about it and say, I notice you've been missing a lot of appointments, or wow, your hemoglobin A1C for your diabetes has gone way up. What's going on? We call that contextual probing. That's a sign they've been listening. Then third, does the person, the real patient, come back with a context? They tell a story that explains what's going on. Doc, it's been really tough. I'm having trouble reading my insulin syringe. I don't think my vision is so good, etc. You get the picture. We call that a contextual factor. And then finally, does the healthcare professional take that information and use it to come up with an appropriate care plan? And we call that contextualizing care. And that essentially is what we're hoping to see doctors and nurses and pharmacists do. When they don't do that, often the result is a contextual error, a care plan that looks good on paper but isn't very useful if you actually are trying to help the patient. So there have been a few key findings from this work that I want to share with you. First of all, that it matters. So what we started doing is we started inviting another part of our research team. We got IRB approval to go and look at the charts at 4 to 6 months after these index visits. And what we discovered is that when the physician figures out what the life issue is and tries to address it, the problem is more likely to resolve. The diabetes is more likely to come under control. The asthma is more likely to come under control. Now that may sound ridiculously obvious, but it's worth proving. So it's just a fancy way of saying that if you're helpful to people and you try to find out what they really need, it does in fact make a difference. The second finding, which really surprised us, was that it didn't take longer. The most common thing I heard when I talked to audiences who were physicians in particular about this is they would say, that's fine and dandy, but we don't have time for this. We're so busy. We're like hamsters on a treadmill. And I would say, well, actually, some of you are doing this pretty well. In fact, some of you are contextualizing care, and your visits are not on average longer. And we know that because we have the timestamps on the audio recorders. And we even see that when we're sending you exactly the same patient. So this is a way of relating to patients. It's a way of communicating. When a patient says, boy, it's been tough since I've lost my job, do you think to yourself, well, that's too bad, but that's not my job? Or do you think to yourself, that's important information, I probably should ask about that? Those are two different ways of thinking. And you actually save a lot of time on the back end because you're not pointlessly ordering unnecessary tests and lecturing to the patient about why they need to do a better job taking their medication. So when we look at this data from an academic perspective, we can describe it. But I think there are some personal lessons here as well. At least there have been for me. And I'd like to just share some of them with you. This is more speculative, it's more qualitative, but after listening to many of these interactions, I think there are some general themes here. So one of the things I should say is it's not just my opinion. My coders listen to thousands of these audio recorders. These people are not physicians. In fact, they were the former actors who played unannounced standardized patients who are perfect for listening to these visits. And often they tell me they want to scream into the audio recorder, why didn't you ask about that? Why did you let that comment pass? Of course, it's no use because they're just screaming into an audio recorder, but that's what they feel like they want to do. So from a third-party perspective, they're hearing something that just doesn't make sense, and it's coming from somebody with years and years of training. So what's really going on here? They also hear health professionals who are very attuned and who contextualize care. What is it that they're doing differently? And I want to share with you sort of 3 insights that I've gained from my coders and from listening to a lot of these audio recordings. First, good communicators are simply trying to solve problems. It's sort of like listening to somebody with a friend. They're not on a higher plane. When you listen, they sound sort of unself-consciously engaged. You get a sense of shared humanity during those interactions. Secondly, you can tell someone's a good communicator by listening to the questions they ask. We're always told that it's so important to be a good listener. But what does it mean exactly to be a good listener? I think it means that you ask good follow-up questions, questions that show you are listening. So when a patient says, boy, it's been tough since I've lost my job, you say, how has it been tough? That's a good listener. Finally, I think good communicators are clear about personal boundaries. They're able to distinguish what's me versus what's you. Just about a week ago, I was supervising a resident in clinic, and he came storming into the conference room where I was sitting, and he was really in a bad mood. He felt like a patient had been just disrespectful to him, and he said, I want to call security. Can I call security? So I was like, well, what's happening? Like, what's the deal here? And this was at the VA. And it became clear that the patient was pretty elderly, frail guy, and this resident looked like he could be a tackle football player. So clearly this was not a situation where you needed to call security. What I discovered was that this resident didn't have boundary clarity. He was so upset at the way he felt he'd been treated that he was losing perspective rather than seeing the patient's perhaps confrontational style as data, as a sign that, well, there's information here. And as a communicator, it's my job to process that information, to ask about it, to inquire about it. And that's why boundary clarity is so important. So in summary, good communicators have this kind of practical problem-solving mindset. They ask appropriate follow-up questions, and they can distinguish what's coming from them versus what's coming from the other person. So I have found that there is almost a life journey in learning lessons from listening to people communicate, from both the good communicators and the people who basically make contextual errors. And I found this to be personally worthwhile as well as professionally worthwhile. So sort of in closing, what I wish for all of you, in addition to your professional success, is that you see this new field that you've joined as a personal opportunity as well, not just to be a better communicator, but to find ways to interact in a personal as well as the professional sphere so that your interactions are not just ways to advance your career, to advance your research, but are also for you personally nourishing. And with that, I wish you all the best.